Why does increasing the dose fix one problem but makes the other one completely useless? This isn't just semantics. It's the difference between a receptor that is ignoring you and a system that has completely run out of fuel. If you treat tachyphylaxis like tolerance by just increasing the dose, you aren't fixing the problem. You are just exhausting the body faster. Let's look at the mechanism. This is the roadmap for today. Adaptive responses to drug therapy. We are going to break this down into two halves. First, the mechanism of failure: tolerance, tachyphylaxis, and downregulation. This explains why the key, the drug, stops turning the lock. Second, we will look at the consequence of that failure: dependence and withdrawal. That is what happens when you try to force the system to reset. Before we blame the drug, we have to blame biology. The fundamental rule here is homeostasis. Your patient's body is not a passive bucket that you just pour chemicals into. It is an active machine that hates change. When you introduce a drug, the body doesn't see therapy, it sees an error signal, a perturbation that must be corrected. Think of it like a thermostat in your house. If a drug tries to force the heat up, your body's automatic response is to blast the air conditioning to cancel it out. This push and pull is the root of desensitization. The more drug you push, the harder the body pushes back. Let's look at the case study of ephedrine. Ephedrine doesn't do the work itself. It acts by displacing stored noradrenaline. It kicks the stored fuel out of the tank to create the effect. But the body has limited storage. If you give ephedrine too frequently, you empty the warehouse faster than the body can restock it. This is the critical clinical point. Once the tank is dry, adding more drug has no effect. You can increase the dose of ephedrine tenfold, but if there is no noradrenaline left to displace, nothing will happen. You have hit the wall of tachyphylaxis. Now let's look at the math of tolerance. This is the classic rightward shift. Curve A is the naive patient, sensitive and responsive. Curve B is the tolerant patient. Notice that the maximum effect, the ceiling, hasn't changed, but the price of admission has gone up. You now need a much higher concentration, a higher ED50, just to get the exact same result. Think of tolerance like biological inflation. On day one, a small bribe of the drug gets the receptor to open the gate. But over time, the receptor gets greedy. It realizes it holds the power, so it demands a higher bribe. The drug has lost potency. It's not that the drug is broken, it's that the exchange rate has crashed. And eventually, you just run out of cash. There are two main ways tolerance happens. First is pharmacokinetic tolerance, also known as dispositional tolerance. We call this the metabolic fortress. The problem here isn't the receptor, it's that the drug never even gets there. Your liver identifies the drug as a foreign invader. In response, it physically builds an army of metabolic enzymes, specifically the CYP450 family. These enzymes act like a biological shredder. They metabolize the drug so fast, it is destroyed and cleared before it can ever bind to the target receptor. The second type is pharmacodynamic tolerance. Here, the drug makes it to the target perfectly fine. The problem is the receptor itself. As the slide says, the receptor exists, but the phone line is cut. It starts with phosphorylation, tagging the receptor with phosphate groups. Think of phosphorylation like noise on the line. The receptor is trying to talk to the G protein to send the signal, but the static is getting louder and louder. Finally, a protein called beta-arrestin is recruited. It physically binds to the receptor and blocks the G protein. This is uncoupling. The drug is still knocking on the door, but beta-arrestin has cut the wire to the doorbell. If uncoupling isn't enough, the cell initiates the retreat. This is downregulation. It is no longer just ignoring the signal, it is physically removing the receiver. Through a process called endocytosis, the cell membrane folds inward, swallowing the receptors and pulling them inside the cell. Think of this like a military retreat. The cell is under siege by the drug. To survive the bombardment, it pulls its soldiers, the receptors, off the front lines and hides them in deep underground bunkers. Once inside, two things happen. Either they are destroyed in the lysosome, the cell's incinerator, or they are put in long-term storage. The clinical result is a reduction in Bmax. The maximum capacity of the system has physically shrunk. But what happens if we do the opposite? What if we block the signal for weeks using a beta blocker? The cell hates silence. It interprets this constant blockade not as therapy, but as a malfunction. To compensate, the cell upregulates. It frantically builds a massive forest of new receptors, desperate to capture any faint signal it can find. This creates a physiological trap trap called supersensitivity. The trap springs if you stop the blocker abruptly. You are removing the dam, but the reservoir behind it is full. The body's natural adrenaline floods into that dense forest of receptors. Because there are so many of them, the response is overwhelming, causing a dangerous rebound effect. This leads us to dependence. As you can see, the scale is actually balanced, but look at the size of the weights. The body has built a massive counter-adaptation to match the heavy weight of the chronic drug. This isn't peace. It is a standoff. The system has adapted so thoroughly that the abnormal has become the necessary. The drug is no longer creating a change. It is simply holding the rope to keep the system from crashing. This is the definition of dependence. A new set point. The presence of the drug is now required just to maintain zero, just to stay normal. This brings us to withdrawal. Withdrawal is simply the removal of the opposing force. If you abruptly remove the drug, that massive counter-adaptation is still there, but now it is unchecked. The scale doesn't just tip, it crashes. Imagine that tug of war again. If the drug suddenly lets go of the rope, the body doesn't stop pulling instantly. It flies backward with tremendous force. That backward flight is the withdrawal symptom. This gives us the golden rule of withdrawal. The symptoms are always the opposite of the drug's effect. If the drug creates sedation, withdrawal creates anxiety. If the drug lowers heart rate, withdrawal causes tachycardia. This brings us to the frontier. Biased signaling. Historically, drugs hit everything, the therapeutic effect and the tolerance mechanism. It's a package deal. But what if we could choose a path? Think of a standard drug. It forces the train down both tracks, giving you the benefit and the tolerance at the same time. But a biased ligand acts like a precision switch. It directs the signal purely to the cure, leaving the side effects behind. That is the goal of drugs like TRV-130. We get the signal without the silence. We activate the cure while avoiding the tolerance. So how do we treat this? When a patient stops responding, do not just blindly increase the dose. Ask one question. What is the time scale? If the response drops in minutes, it is tachyphylaxis. If it is acute, the tank is empty. Pushing more drugs is useless. You need a drug holiday, a break to let the stores replenish. But if it is chronic, occurring over weeks, it is tolerance. For tolerance, you can increase the dose or rotate the drug. But if you choose to stop, you must taper. You have to lower the dose slowly to give those upregulated receptors time to fade back to baseline. But here is the hard truth. Everything you have learned in this playlist so far, agonists, antagonists, tolerance, is based on one assumption, the occupancy model. You have to hold the receptor to work. But what if that model is dead? We are entering the era of event-driven pharmacology. We are no longer trying to block the target. We are going to delete it. You aren't ready for modern medicine until you understand protacs and molecular glues. Click here to see how we hijack the cell's trash compactor to cure the undruggable.